First, try your regular treatment. It fails, then you start ECMO early. So when you start ECMO early, the steps are initiation, maintenance, and removing the patient from ECMO. In initiation, once you've decided, you know the circuits, you know the oxygenators, you know which pump you're going to be using, you know which cannulas you have selected, you know your indication is right. Then you want now to anticoagulate the patient before you put in the cannulas. So the patient is anticoagulated with the heparin. And then following the cannulation, the patient is connected to the ECMO circuit. And then you start the flow with 20 ml per kg. So if it is 50 kg man, you start with 1 liter per minute and then gradually increase every 5 to 10 minutes to reach the desired flow. Now, what is the desired flow? We will come back to you. So reasonable targets when you are doing is an arterial hemoglobin concentration of greater than 90% on a VA ECMO and greater than 75% on a VV ECMO. So in a VV ECMO, removal of carbon dioxide becomes very important, and arterial oxyhemoglobin, because here the heart is not supported. So even a greater than 70% for a VV ECMO is good enough. A venous oxyhemoglobin saturation of greater than 70% for a VA ECMO. Okay, and other signs of tissue perfusion like lactates, your arterial blood pressure, all will tell you the correct things. What do you monitor once a patient is on the ECMO? You look at what is known as the activated clotting time. So it is crude, it is simple, it's available at bedsides. Normal ACT is around 80 to 120 seconds, and you keep your targets at 180 to 220 seconds. So when you cannulate, before you cannulate, you give heparin at a bolus of almost 100 units per kg. You have an ACT of greater than 300, and then you maintain your heparin infusion. You target your ACT, like I said, 180 to 220. If it becomes greater than 300, you withhold the infusion. If it is greater than 280, there is a risk of bleeding. So you start reducing your heparin infusion. You're monitoring ACT every hour. And less than 160, do not want because there is thrombus. So you will have to repeat the bolus heparin. So this is very important to keep monitoring your clotting. What else do you monitor on a patient on ECMO? You monitor his hemoglobin, his hematocrit, PT-INR, PTT, fibrinogen, platelets. Like I said, ACT measurements 1 hourly at the bedside. Try to maintain the hematocrit between 30 to 40. Maintain the platelets greater than 80,000. And INR goal depends on basically whether the patient is at high risk for bleeding or not. Maintain your fibrinogen levels greater than 150. So other things, if the patient is not tolerating heparin and he's having a heparin-induced thrombocytopenia, what else can you use is, you can use direct thrombin inhibitors like bivalirudin and agatoban. And you can also use low molecular heparin. They are not as effective as heparin. Most of us only use heparin. Like I said, we monitor all the coagulation profiles, hematocrit, and everything else which I mentioned earlier. You also measure the pressures. You measure the pre-oxygenation pressure and the post-oxygenation pressure. You also measure the continuous venous oximetry. Like I told you, we had targets for VV ECMO and VA ECMO. So you need to know your targets and try to maintain those targets. And you want to monitor your neurological status. So you will be giving him sedation, vacations, and trying to assess his neurological status repeatedly. And anticoagulation, like I said. When the patient condition he is recovering and you can make out